Hello, everybody. I'm Dr. Ina Park, and I'm the Medical Director of the California Prevention Training Center. And I'm very excited to welcome you to our Expert Hour webinar on vaginitis. I'm just going to go through a couple of introductory slides, and then I'm going to introduce our speaker, Caroline Mitchell. So the California Prevention Training Center is a multidisciplinary training and capacity building assistance center. We are funded by CDC, and we're part of a national network of prevention training centers. There's 8 of us in the country, and we really target providers as well as public health professionals serving persons and communities impacted by STDs and HIV. So just to let you know, please visit our website. We have lots of resources. We have links to our old webinars and videos that we've produced. We have opportunities as well to provide technical assistance. And those of you who are willing to come to California or are local, we can also offer clinical precepting as well on STD care. So this is an important slide because those of you who are taking care of patients who have STDs, who might have a complicated case, please feel free to reach out to us. This is a national consult line called the STD Clinical Consultation Network at stdccn.org. And just to let you know, for those of you who happen to be in Arizona, we're going to be hosting an STD, HIV, and tuberculosis update on May 7th. Oh, I'm sorry, that just passed. These are old trainings. I'm sorry, this is from the last webinar that we did. So just to please like us on Facebook and follow us on Twitter at CaliPTC. And we want to hear from you. So in your chat box, while Dr. Mitchell is talking, when you have questions, please go ahead and fill those in, and we will answer those at the end. And if we run out of time, then we will actually have Dr. Mitchell answer some of those, and we'll post those to those who registered for the webinar. So here's your Caroline Mitchell's disclosures. And this is a statement on continuing education credits, but you will receive information about how to claim your CE credits following this webinar. There's going to be a link sent to the email that you used to register. And just as an FYI, the CMEs and continuing education units are free. So let's enjoy the course. And without further ado, I'm going to introduce Dr. Caroline Mitchell. So she is a colleague from the Massachusetts General Hospital in Boston, and she's an assistant professor in the Department of OBGYN. She also happens to direct a laboratory there that conducts studies on the vaginal microbiome and how it relates to reproductive health and disease. We are so fortunate to have her with us, and I'm going to let Caroline Mitchell take it away.
Wonderful. Thanks so much, Ina, and hi, everybody. In a minute, you're going to see my slides when I get to share my screen. There we go. And I'm going to try my best to go under time, because the fun part is always the questions. Unfortunately, the way we're set up, I can't see your questions in real time, so apologies, but I'll again try and go under time so we can do questions at the end. You've seen my disclosures, and then the additional disclosure for this talk is that some of the treatment regimens we're going to discuss are not FDA approved for the specific indication for which they are mentioned. These are our learning objectives. I think these are pretty familiar to most of you on this call, but we're going to go over hopefully some of the nuances of diagnosis, testing, and the many, many challenges in this area clinically. So we'll start with this first case. This is a 27-year-old G1P1 who presents with 3 days of worsening, itching, vaginal discharge, some dysuria, one sexual partner for the past 3 years, gestational diabetes in her pregnancy a year ago, OCPs. She's douched a little bit to relieve her symptoms, but that hasn't helped. And her vulva is red, edematous. There's some excoriations. Speculum exam reveals thick, clumpy discharge, no mucopurulent discharge from the cervix, and no CMT. So I put the sensitivity and specificity of testing next for our three main causes of vaginitis because there's quite a range. And one of the things to note here is the PCR line. Many of these PCR-based tests, the Sure Swab, the New Swab, the many swabs you can send for $1,000, those sensitivities and specificities are only from company literature and not from published literature that I can find at least. And so look a little better than some of the other tests on this grid, but again, not from peer-reviewed literature that I can find. And I am an old school person. I really like the microscope and the wet mount because it's immediate and you can get an answer right away for many things. But in terms of sensitivity and specificity for BV and Trich and yeast, all of those, sensitivity at least is not as good as some of the molecular or culture-based tests that are done. Specificity is usually quite good, and that's where the more molecular-based tests are a little bit worse. So I think you just need to know what test you're using. And many of these tests perform very well in symptomatic patient populations the first or second time. But I think something to remember is if you're sending the BD affirm for someone who you think has BV over and over and it just keeps coming back positive, 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 but she's not getting better, it's because the BD affirm just tests for Gardnerella vaginalis and not for the other bacteria associated with BV. So the fifth time you send it, it may be an indication it's not BV because it's not completely specific test. So for our patient, this is what we see under the microscope. I think it's pretty clear to everyone what this is. Yeast, I gave you a clinical scenario of discharge, itching, erythema. It's very classic. But one of the things I'd like to emphasize during this talk is that symptoms are 100% not predictive in vaginitis. And we should always test. We should always test people because you can't diagnose vaginitis over the phone. So yeast, most of the time our pH is normal. Lactobacilli are usually present. You can see hyphae as in the picture on the right or budding yeast as in the picture on the left. And 96% of the time, what we find when we find vaginal yeast is Candida albicans. But is it really yeast? And this gets to the question of not diagnosing over the phone. This is one of my favorite studies, and I was done around the time that yeast medication became available over the counter, the sort of first of the vaginal creams. And I picture people lurking in the aisles of a pharmacy, which is not actually the case. When a woman came up to the counter at the pharmacy with this over-the-counter yeast medication, the pharmacist asked if she would like to find out if she really had yeast. If you just took her unopened box of yeast medication down the street to the clinic, they would test her and find out if it was really true. And when they did that, they found that only about 35% of the women who were buying a medication to self-treat yeast, only 35% actually had only vaginal yeast. Some had yeast plus something else. Several had BV, some had Trichomoniasis, some had others, including gonorrhea or chlamydia, and some appeared to be normal. The patients who were worst at correctly predicting whether they had yeast are people who said they'd had yeast before. So to emphasize, patients who say, I know it's yeast because this is how it always is when I have yeast, trust but verify, because often we don't actually know. In terms of treatment, all of these options over the counter have comparable efficacy. You can pick whatever one you want. It doesn't really matter which one, except for the fact that as you go down this list to the less frequent dosing but higher concentration, you often will run into more irritation for patients. I think many of you are probably familiar with that, but so I tend to do for longer at lower concentrations because many of the people I see have a lot of irritation, and these medications can just make that worse. You can also prescribe topical prescription medications, and again, all of these have pretty comparable efficacy. There are not many head-to-head trials, but overall, they get the job done. And then oral agents, so fluconazole, 150 or 200 milligram tablet once for mild to moderate infections. And then if you have moderate to severe cases, you may require an extra dosing. The CDC recommendation is a dose on day 1 and a dose on day 4. Commonly, what many people do, I think, is doses on days 1, 4, and 7. Now, moderate to severe cases, that is people like our patient who have lots of erythema, excoriations, just tons of really bothersome symptoms. Could also be someone who's immunosuppressed, someone with poorly controlled diabetes, someone who has a reason that the infection is likely to be worse. Those folks, I would just empirically do the longer dosing of fluconazole or the longer dosing of the topical medication. Okay, so we successfully treated her this one time in clinic. We tested, we knew it was yeast, but she comes back a year later. And in the meantime, she self-treated for symptoms several times with over-the-counter products because now she knows she had yeast. She went to an urgent care and they did an exam and said, oh yeah, you totally have yeast, and got some fluconazole, and that helped. And she again has symptoms of itching, vaginal discharge, and pain with sex. So is this recurrent yeast? Is it resistant yeast? She's been treating it. Has it ever really gone away? And is it even real yeast? So I think we always need to ask this question in the red box of ourselves. We always need to test because this may not actually even be yeast. However, if we do test and it is yeast, most likely it is recurrent, such that it was treated effectively, symptoms went away, and now they're back, but it is likely to still be sensitive to the medications we use, like fluconazole. Recurrent is defined as 3, sometimes 4 episodes in a year, but I think 3 is totally fair, or 2 episodes in 6 months. And the recommended treatment for this is suppressive fluconazole. So fluconazole once weekly. And in the study, this was done with a 150 milligram tablet. Some people use the 200 milligram tablet, and in some cases, the 200 milligram tablet is better covered by insurance. So what you can see, this is the randomized trial that was published in the New England Journal in 2004. The solid line is women on fluconazole. The dotted line is women on placebo. The green line, dotted line, is where they stop therapy. And you can see while people take this weekly suppressive dose of fluconazole, they do very well. And then when they stop, many people recur. And so this is what I tell patients is that while you're taking this, most people do great. And for some people it is curative, but many people it comes back after you stop. So this treatment was for 6 months. The study was for 6 months, and that is usually the recommendation, is to do suppression for 6 months. Many people will be terrified to come off the fluconazole suppression. And I do for some people. I like people to try coming off, but I will put people on for longer. And the question is, if you're doing weekly fluconazole, should you be checking LFTs? My personal practice is if I have someone on weekly fluconazole for about a year, that is when I check LFTs, or if someone develops symptoms, or if someone has a known problem with their liver. That is personal preference. As far as I know, there are not clear guidelines about when one should and should not test, but fluconazole is overall well tolerated. So the other option for our patient with recurrent yeast symptoms and recurrent yeast, if we see it under the microscope, is that it's now resistant to our medication. How common is resistant yeast vulvovaginitis? This is a case series of all the patients seen in the Wayne State Vaginitis Clinic between 2000 and 2010, of all the Candida isolates that they had during that time, which included 4,000 new patients. Only 25 had resistant Candida albicans, fluconazole resistant Candida albicans. However, most of those, so 60%, were in the second 5 years of that period. Most of them had been on prior suppression, and many of those isolates were cross-resistant with other azoles. And so I think as we use more and more suppressive fluconazole, so remember that New England Journal paper was published in 2004, so since this case series was published, it's only gotten more prevalent. I think we are seeing more and more Candida albicans, although there's not much documentation out there. Resistance is considered an MIC greater than 2. The median for this case series was 8, and the range was 2 to 128, which is quite impressive. So if you do get one of these resistant Candida albicans isolates, and I'll say, when you have someone that you're wondering about recurrent versus resistance, should you do a fungal culture? That's really the only way to know about resistance. For many people, a fungal culture is cost prohibitive and is really a barrier. So I think it's very reasonable to try empiric suppression. And if that doesn't work, if the symptoms persist, to then move on to culture and ask for resistance testing. If you do identify that you have a resistant Candida albicans, usually the first go-to for me is boric acid vaginally for 14 days. This is not necessarily because it's the most effective, but it is certainly cheap, easy, and relatively well tolerated. And if it works, that's wonderful. For maintenance, some people with resistant Candida albicans, what's out there so far is published strategies to really try and mitigate the symptoms. Eradication is very challenging. And so some people put folks on twice weekly fluconazole at a higher dose. I will say I have done that, and I think I've just made people way more resistant to fluconazole, so it is not something I would recommend, although it is out there in the literature. Other things you can try is ketoconazole or itraconazole, but again, in the case series from Wayne State, many of these isolates are cross-resistant. You can do suppressive boric acid under the same principle as the suppressive fluconazole. Vaginal amphotericin compounded is an option, or vaginal gentian violet. And if any of you have used this before, gentian violet is quite violet, and it will make everything else violet. And so if you're using this, it is something that keeps you kind of in the house and sitting on fabric that you're willing to ruin, because it really is quite permanent. So ideally, I think when we think about treating recurrent yeast, we should be considering the fact that there may be more and more resistant Candida albicans out there. Also, Candida albicans does maintain sensitivity to these antifungals at low pH, like the low pH of the vagina, but not all isolates do that, and not all species maintain that sensitivity to azole. So all of our sensitivity data is based on fungemia, so infection in the bloodstream, and not in the acidic pH of the healthy vagina. Non-albican species are far less common. If you do have a non-albican species, Candida glabrata is the most likely. You'll also see these others in these proportions. Glabrata is responsible for symptoms maybe about half the time that it's present, and this is based on symptoms going away when you eradicate the isolate. So if you're treating the yeast and the symptoms aren't going away, especially if it's one of these non-albicans isolates, which are very hard to eradicate sometimes, it is worth stepping back and thinking about whether, in fact, there is another cause for the symptoms. Because otherwise you go down a rabbit hole of just treating over and over again, and you may not actually be treating the cause of the patient's symptoms. For Candida glabrata, half of isolates are resistant to azoles, just a priori. I do still, if I don't have sensitivity testing with Candida glabrata, will start with fluconazole because it's well tolerated, it's oral, and if it works, wonderful. If it does not, then boric acid is usually my first go-to. With the fluconazole, I do sometimes do a topical azole like clotrimazole or turconazole, and I do sometimes do this higher dosing, although not always. And then another option, which is case series and case reports, is this compounded amphotericin B 4% and flucytosine 17% nightly for 14 days. The flucytosine part of this can cost $1,400 for that 2-week course. So this is cost prohibitive for many people. We have had some success in varying amounts getting insurance to cover this. And I'd be happy to share our sob story letter with the group if that would be helpful, because we cite all of the available studies, and often we just fax all of those studies to the insurance company and try and overwhelm them with the limited data that exists for this. So for the patient who's having these recurrent symptoms, one of the most common questions is, what else could I be doing to keep this from happening? Are there behavioral things that I'm doing that are putting me at risk? OCPs are a common thing that people think about. Half of the studies show no increased risk, and half of the studies show an increased risk. Again, it really comes down to whether oral contraceptives are the optimal method for contraception for your patient, in which case, I think in the absence of a clear skew to the data, contraception is better than no contraception. However, if something else is of interest to your patient, then trying that would not be an unreasonable thing to try to reduce the risk of recurrent yeast. Diabetes obviously is a risk. The diet studies are all over the place, and so my recommendation to people is really to just try and avoid processed sugars, eat vegetables and whole grains, really the advice that we give to all people. A few studies have associated oral sex or frequent sex with recurrent yeast, but there are no partner studies that I've been able to find. And in my experience, treating the partner has not been that helpful in reducing recurrence. So associated with sex, but whether that's because it increases the discomfort of symptoms or whether it truly increases culture-proven yeast is not clear to me. The clothing choice, so there is actually one study, I need to update this table, of pantyhose. And people who wear pantyhose do seem to have more culture-proven yeast than people without pantyhose, but it is a study from the 1970s. And so the methodology is, the method section is quite scanty. But overall, the other studies that are out there suggest that symptoms are definitely worse with tight clothes. But whether it is truly more culture-proven yeast, to me, is not completely clear. But I do tell people that, eating a healthy diet, if there's another contraceptive method you'd like, we could try that. And then wearing loose clothes often makes people far more comfortable. And should you recommend probiotics? That's the other question we often get. Is, I've been taking this probiotic for the past month and think it's really great. Unfortunately, yeast in the laboratory absolutely kills yeast. And the yeast that is used in the laboratory is often the dairy-based lactobacillus, which are happy in the gut. It's not the vaginal-based lactobacillus. And when you look in vivo, in studies of people, here in this graph is looked at 151 HIV-negative sex workers in Mombasa. Green bars are symptomatic or just vulvovaginal candidiasis, and the blue is symptomatic vulvovaginal candidiasis. So women with VV compared to women with mostly lactobacillus dominant vaginal microbiota, you can see overall had far less yeast and less symptoms than the women who are lactobacillus dominant. And if they were VV negative and lactobacillus dominant, that blue bar is the highest of all, so very symptomatic. In a study in the US of over 13,000 pregnant women, here green bars are women with a lactobacillus dominant vaginal bacterial community, and blue bars are women with VV. The left side is candida, the right side is no candida detected in the vaginal specimen. And I think what you can see is that there's really not much difference between the two. If anything, the women who had candida were more likely to have lactobacillus, although it's not statistically different. So in the vagina, yeast and lactobacilli are friends. And probiotics, we'll talk about that a little bit later in the talk, but to date have not been very good at changing the vaginal microbiota anyway. So overall, I think probiotics for your vagina are a waste of money. So in pregnancy, Fluconazole, I think many of you have probably seen this data. For a long time, it has been recommended not to use fluconazole in pregnancy, but I confess that in the past I was a little more fast and loose with fluconazole. But this study came out, 1.4 million pregnancies, a linked administrative database, and this includes women who the system knew they were pregnant. So it's not the 4 and 5 week pregnancies, it's 8 to 10 week early pregnancies who received fluconazole. They were matched with 4 controls, at least one of whom had topical azole exposure, so who also had yeast, but treated with a topical azole instead of the oral fluconazole. And fluconazole was associated with increased risk of miscarriage or pregnancy loss between 7 and 23 weeks. And this seems to be a real finding. They also did a sensitivity analysis looking at people who'd received antibiotics. And it really does seem to be, it's not the yeast, it's not infection in general, it's the fluconazole. So this has really changed my practice in pregnancy. No fluconazole, no way, no how. So what if this patient was a little bit different when she came back to you? So all she said, for the past year, I've been having this miserable itching. It's terrible. I have discharge, so uncomfortable. I've used the yeast creams. They help a little bit. But this is what we see on our exam. This erythema, this little bit of thickening of the skin, kind of raised edges. And this is lichen simplex chronicus, which is chronic inflammation and irritation of the skin. Sometimes we call it the scratch that itches, because the more you scratch it, the more it itches, the worse it gets. And so here is where often those topical azoles cause a ton of inflammation. People get treated over and over. And really what they need is to stop using all topical things. Use something simple like coconut oil or Vaseline to protect the skin, and probably some topical high potency steroid ointments to treat that vulvar irritation. Okay, case 2, and I'm gonna be cognizant of time and really try and get us under the wire here. This is a 23-year-old heterosexual woman presenting with classic symptoms of foul-smelling discharge for about a week. Douching didn't really relieve her symptoms for long. No new sexual partners, no unprotected sex. We use external condoms pretty regularly most of the time. pH is 6, and on microscopy, there you go. Some pretty great clue cells there, and then a couple polys hanging around as well. So again, I said at the beginning, and I'll say it again, that the classic symptoms we talk about of discharge and odor are often present and make it seem very likely that someone has BV, but they are not 100% predictive. And so we always need to look. I prefer the microscope, but I know the microscope is going away for many people. But Amsel's criteria, an elevated pH higher than 4.5, clue cells, discharge, and the whiff test. So the picture I showed you before of the clue cells, that was taken with a phase contrast microscope, which is the best kind of microscope to have if you want to study vaginitis, but not one that most people have. So I think here on the far right, there's a phase contrast microscope picture, but more often you're going to see pictures like the one in the middle or on the left. Now, only which one of these is a clue cell? Because often our microscopes are foggy, they're dirty, it's in the ER, who knows? So only one, number 1 here, is our clue cells. That cytoplasmic stippling in picture number 2 does not count. You have to have that fuzzy sort of edge of the epithelial cells that some people describe as the cell being pressed in sand, or it looks like a chia pet to me. So we've diagnosed her with BV because she has an elevated pH, she has discharge, she has clue cells. So what can we use to treat her? And it turns out it really doesn't matter. Overall, the cure at 1 month is pretty similar between the 3 recommended regimens from the CDC, which is oral metronidazole, vaginal metronidazole, or vaginal clindamycin. And you're looking at this table and saying, wow, that is actually pretty terrible. 60%, 30%, 42% in that first column. And that is the CDC or the FDA definition of cure, which is Amsel's negative and Nugent negative. So no clinical signs, and then the Nugent score is the Gram stain score. And you have to be negative and negative for the FDA. Probably what more of our patients care about is being symptom-free, and that would be the far right column. Many of those studies were just like, hey, it didn't seem like they had BV anymore. And those rates of cure are much higher. Also, the rate of cure is much higher at 2 weeks, but patients care about whether they're coming to see you again next month at the end of their period. And so, I think this table shows really you can pick just about any of these and it will be fine, although not great. But B, that our ability to cure BV is really pretty poor. And so the other things on this table, tinidazole, I would say, is the one caveat to this. I think these success rates are really pretty terrible. And so I don't use tinidazole that much. Secnidazole is the new single dose sachet of granules, which you're supposed to put in applesauce or yogurt. It is a single dose treatment, so that's its benefit. Although I've had patients tell me they thought the texture was really kind of gross. So overall, pick your poison. They're all pretty comparable. And I will say I tend to do a lot of topical therapy for BV because I prefer not to disrupt the gut microbiota with an oral antibiotic if I don't have to. In terms of behavioral associations with recurrent BV, it is probably mostly about sex. Condom use is protective. Having a new partner puts you at risk. Having a consistent partner, if you get recurrent BV, also puts you at risk. And a female partner with symptoms is one of the highest risk cases. Hormonal contraceptive use is protective, although we're not totally sure why. And douching does seem to increase your risk. However, many of these studies are really association, and whether it's just people are douching because they have symptoms or whether they have symptoms and BV because they douche is not always 100% clear. So what I do for patients, I encourage them to use condoms. For female partners, we're going to talk about partner treatment, and there are not any studies of treating female partners of women with BV, but I think it would be very reasonable to ask the partner to come in and be screened, or even to provide treatment for her, because I think it seems like there's a very good case that BV is a transmitted infection between two female partners, although the data to support that are not completely there. For male partners, we'll talk about that later, the data about treatment reducing the risk of recurrence is not as robust. So for people with recurrent BV, which is 3 episodes in a year or 2 episodes in 6 months, similar to what we saw with fluconazole for yeast, suppressive treatment is the gold standard. And so using twice weekly Metrogel is what's been studied in a randomized trial. The red line here is folks getting Metrogel. The yellow line here is people getting placebo. And again, while people take the medication, they do great. And there's a statistically significant difference in recurrence between those two groups. But when you stop using the Metrogel, the BV recurs in many people, although not all. And probably the folks in the Metrogel arm are a little bit better off than those in the placebo, although that difference is not statistically significant. So fair enough, you say, but I've given everyone the Metrogel and I've done all the treatments. What else? Because the BV is still coming back. So there is an idea that BV is associated with a biofilm. And if we use something that could disrupt the biofilm, that might decrease the risk of recurrence. And boric acid is the thing that has been proposed as a biofilm disruptor. In this study, this is a case series of 51 patients. They all received oral treatment with antibiotics, then 21 days of nightly vaginal boric acid, and then the 16 weeks of twice weekly vaginal metronidazole suppression, similar to the graph you saw on the previous page. And overall, if you overlay the metronidazole suppression phases of these studies, you can see that they're really very similar. So starting out with the 21 days of boric acid doesn't really seem to get you to any different place than just doing the suppressive vaginal metronidazole. So boric acid, it seems to me, does not seem to have an additive benefit, but it is a little bit different, and some patients like it a little bit more than Metrogel. It's a little less goopy depending on the formulation you use. So I think of it as a part of my armamentarium, but I don't think it's a panacea. There is a new product out there, as TOL 463. This is a study that was published in CID just 2018. It was a randomized trial of two formulations of this product, which is boric acid plus EDTA. And it was a gel versus an insert, sort of a suppository. Cure here for BV was 0 AMSEL criteria, and to get into the study, you had to have all 4. Cure was evaluated at 9 to 12 days. Symptomatically, 88 to 93% of people got better, but cure here, whether in the green intent to treat or the blue modified intent to treat, was between 50 and 60% at 9 to 12 days. So that is probably not as good as the 9 to 12 days results for antibiotics, suggesting again that boric acid on its own is probably not better than antibiotics, but as a part of our armamentarium and as a tool to help may be very useful and certainly seems to have some benefit. Although again, in this study, there was no placebo arm for comparison. So what about probiotics? Because everyone says, well, I've been taking my probiotic, my 50 billion, whatever it is. So this is a graph of the various randomized trials of probiotics for prevention of recurrent BV. I'm not going to talk about probiotics for treatment of BV because they're just not as good as antibiotics. In this graph, blue is the probiotic arm of the study, orange is the placebo arm of the study. In the table across the bottom, you'll see the N in bold of the number of women in these studies, some of which are actually quite large. The duration of treatment, which is quite variable. The time of follow-up, and you'll see some of these are we treated for 30 days and we followed up at 30 days. Most of the agents in this graph are vaginally delivered, although a couple are oral. And if you look at these three, where the blue and the orange bars are significantly different, all of those were the oral agents, and all of them included in their oral probiotic Lactobacillus rhamnosus GR. There is a Lactobacillus rhamnosus GG strain, which is commonly found in a lot of gut probiotics. That one does nothing for the vagina. This one, when the investigators in at least one of these trials actually cultured the vagina after giving people the probiotic and found this lactobacillus in the vagina in those people. And so there is some biologic plausibility to this. However, many of these studies have some methodologic flaws in that they didn't do an intent to treat analysis. There's differential loss to follow-up. And so what I still tell people is I really think probiotics are a waste of money. If you feel like you really want to try something, I would pick one with this strain in it, but overall my take is still a waste of money. This last one on the end is a vaginal Lactobacillus crispatus probiotic that's available in Europe, and this is a small study of 98 women. All of the other vaginal probiotics there are mostly gut lactobacillus isolates. This is the only one out there with a vaginal isolate. Again, this study has really tremendous methodologic shortcomings in its reporting, and so again, it's biologically plausible, but I'm not convinced by these results. I will say there is a company in the United States that's making a live biotherapeutic product that uses a Lactobacillus crispatus isolate. The phase 3 trial, I believe, has completed enrollment, and we may hear results in July at the ISSTDR meeting. And that is being run as a phase 3 trial to get an FDA approved, it's called a live biotherapeutic. So it's not a probiotic, it's not a food supplement, it's real FDA regulated medication if it's effective. So thinking about other ways we could prevent recurrence, should we be treating the male partners? Is BV a sexually transmitted infection? And so we should be preventing transmission of whatever the heck it is that is transmitted. These studies are all older, and they all include some treatment regimens for women as well as for men that are not optimal. There's a single 2-gram dose of tinidazole, single 2 grams of metronidazole. So they're not the optimal treatment regimen for anyone in the study, but the blue bar here is no treatment for the male partner. The red bar is treatment for the male partner. There is really not one bit of difference between recurrence in the female partner, whether her male partner is treated or not. Why this still remains an active question is the circumcision studies from Rakai, Uganda, where in men being randomized to circumcision for HIV prevention, those who were randomized to immediate circumcision compared to those who were randomized to later circumcision, the female partners of the men who were circumcised early had a 50% reduction in BV in the year following their partner circumcision, suggesting again there really is some transmissible thing. We're just not good at knowing what that is, and we're clearly in these treatment studies not very good at eradicating it in either partner. And I think as many of you may know already, there was also a study of Purell treatment of the penis, which was ineffective in preventing recurrent BV and actually caused discomfort and possibly worse outcomes for both partners. So male partner treatment is not currently on the table. So case number 3, and hopefully this will take us in so we'll have some time for questions. So this is a 42-year-old woman presenting with complaints of large amounts of vaginal discharge, some irritation, some postcoital bleeding, 2 sex partners in the past 6 months, and uses an IUD. On exam, lots of discharge, lots of erythema, petechiae, no CMT. And this is what you see in your speculum. And then this is what you see in your microscope. And often what I remind the residents when I'm talking to them about microscopy is when you're doing your saline prep, starting at the 10x and just scanning the slide for motion is going to be your best way of trying to pick up Trichomonas. Looking just for those motions and doing just a quick scan at 10x also gives you a sense for what's on the slide in general. But one of the reasons Trichomonas, the sensitivity of the wet mount for Trichomonas is just 60% is the trichomonads die. And in this picture where the trichomonad is not moving, it's very similar size to the white blood cells that are around. And if it's not moving, you're not going to know exactly what it is for sure. So they might die and stop moving, or we're just focused on the epithelial cells and we don't even see the trichomonad jerking around in the corner. So Trichomonas often discharge, pH is often elevated. There doesn't really seem to be an association with bacteria, although women with trich may also have BV. In the 2015 STD guidelines, the recommendation was metronidazole 2 grams single dose or tinidazole, when tinidazole has a longer half-life, so that might be a more recommended therapy. Partner treatment for anyone who was in contact in the past 60 days, and then abstinence until 7 days after therapy for both. However, there was a randomized trial of treatment in HIV-infected women that found that the single dose therapy was not as effective as a full 7 days of twice daily metronidazole. And in fact, at both 8 to 12 days and then at a 3-month follow-up, the 7-day therapy was much more effective. And so in the 2015 guidelines, the recommendation was that for HIV-infected women, we should be using this longer-term therapy and not the single dose treatment. Subsequent to that, there has been another study, an open label RCT of the 2 gram single dose versus the longer course in women in Mississippi, Louisiana, and Alabama. Of the 623 women randomized and were randomized, they were included in an intent to treat analysis. And then 540 were included in a per protocol analysis, which means they came back and had their follow-up testing to find out if the treatment worked. The outcome was measured by a trich NAT or culture. People could follow up anytime between 3 and 12 weeks, although the goal was 4. And here the blue bar is the single dose, the red is the 7-day dosing, and the percent recurrence or failure on the y-axis. And you can see that the red bar, the 7-day dosing, performs better in everyone, whether you're BV positive or negative. One of the critiques of this study is that that's a pretty high failure rate across the board. So is this failure? Is it reinfection? And the author's rebuttal is that they did a ton of sensitivity analyses and they really tried to restrict their analysis to people who it really seemed like treatment failure, and still the 7-day dosing pretty much always wins. So I believe in the upcoming 2020 CDC guidelines, there certainly will be discussion, and I suspect that they're going to change the recommendations to 7-day dosing for just about everyone. All right, and our final case is a 47-year-old woman who presents with persistent complaints of vulvovaginal irritation, lots of discharge, not really an odor, and lots of pain. She's got swelling, discharge, erythema. She's got sort of erosions at the vaginal introitus. She's got inflammatory cells under your microscope, lots of parabasal cells, no lactose, and her pH is elevated. When you look under the microscope, this is what you see. So what you'll see here is you'll see a lot of epithelial cells, nice healthy epithelial cells, a parabasal cell here, maybe here, and maybe this is a parabasal cell, and certainly over there, and then just tons and tons of white blood cells all over the place. So really the first thing you should think about when you see something like this with anyone is gonorrhea, chlamydia, trichomonas. That should be the first thing you think. But in many people, those tests are all negative, and still you have this significant amount of inflammation. Also, if you look at sort of the background microbiota in this slide, it's hard to see, but these are mostly really small coccobacilli and not many of the rods that we would associate with being lactobacillus. So this is desquamative inflammatory vaginitis, described really mostly in case series, probably akin to what's called aerobic vaginitis in several publications from Europe. Clinically, it's characterized by tons of discharge, lots of discomfort, pain, erythematous vagina, and just the copious sheets of white cells under the microscope. So if you're not looking under the microscope, this may be something that you're not going to see, because it could look like BV, it could look like yeast, and you might treat people over and over and not know why they're not getting better. So at some point, it requires either a gram stain in your lab to look for polys, or looking under a microscope. The parabasal cells, we think, again, here is because there's just so much inflammation that the vaginal lining is turning over, and so you're seeing these parabasal cells because the vagina is becoming thinner. Treatment, we have very little idea about what causes this, and you can tell that because you can either treat it with clindamycin or vaginal hydrocortisone. And the real key to treatment here is duration. The initial treatment needs to be daily for 4 to 6 weeks. I tend to do clindamycin just because I feel like there's more safety data of that for long-term use. There is one case report of someone getting C. diff after vaginal clindamycin treatment. And so hydrocortisone overall is likely to be very safe. It's formulated in many cases for mucosal application for hemorrhoids. You can either use those rectal suppositories that are 25 milligrams, 1 or 2 of them, or you can get a compounded 100 gram per day suppository or a 10% cream and use 3 to 5 grams daily. Often people need maintenance 1 to 2 times a week. This is very challenging to treat, but you can make people far more comfortable with this type of regimen. So the other thing I'll ask is that in patients who have discharge, irritation, burning, itching, pain with sex, and you've treated them for your infectious vaginitis and the symptoms have not improved, or they improve transiently and come back and you don't really see anything, or you see a little bit, always think about vulvodynia. And if you're not a gynecologist, this is not necessarily something that you're going to know how to treat. In fact, many gynecologists don't like to think about this, don't like to manage these patients, but vulvodynia occurs in between 9 and 16% of women, depending on your study. It is incredibly common. It's incredibly distressing for people, and many people see more than 2 or 3 physicians before they ultimately receive a diagnosis. So always look for the infections first, treat the infections first, but if the symptoms don't go away, always think about vulvodynia and consider a referral to someone who can manage those symptoms. And I think overall, my takeaway from doing this work and whenever I put together this talk is that we're doing okay for some things, but we really need more innovative solutions, especially for recurrent BV and more for fluconazole-resistant Candida albicans. Troubleshooters definitely need a lot more help. So many thanks to you all for your attention. Many thanks to the many wonderful folks in infectious disease who shaped my career along the way. And I will look forward, hopefully, to a robust set of questions.
Hi, everybody. One second. Sorry, everybody, we had a little bit of feedback, but please type in your questions for Caroline Mitchell in the chat box, and we'll pass them along to her. We have a separate chat box just for her, and we do have about 9 minutes left for questions.
All right, I'm going to just start from the...
So your questions are rolling in, and Elizabeth Olson, our coordinator, is going to move them over into Caroline Mitchell's chat box so she can address them.
Okay. So this question about the fluconazole, no fluconazole during...
Oh, and Caroline, we're getting a request to show the Trichomonas video again at the end of your talk, if that's a possibility.
Sure, absolutely. I'll share my screen and pull it up again. So, although actually I can't see the questions when I share my screen. I'll do it right at the end, sorry. So no fluconazole during 7 to 26 weeks of pregnancy. It's painful, but yeah, based on 1.4 million pregnancies, and it's a real increased risk for miscarriage and late miscarriage too. So I hate saying that because topical azoles are much harder for people, but yeah, no fluconazole. And for yeast vaginitis, is it better to avoid all dairy? No. Certainly not. There's no data-driven recommendation that I can give you on that.
Caroline, we're cutting and pasting some questions into your box. I don't know if you can see them.
Yes, can you not hear me? I've been trying to answer them. Can you hear me? So for yeast vaginitis and dairy, again, overall, what I tell individual patients is go ahead and try what makes sense to you, but try not to make yourself miserable with the diet because we don't have data. And if you're already miserable with yeast, why be miserable because you're not allowed to eat your favorite things? Boric acid. So the boric acid suppositories, you can either have them made by a compounding pharmacy. Our compounding pharmacy, it's about $75 for the 2-week supply. There are multiple providers on Amazon, many of which are homeopathic medication manufacturers. And for a jar or a bottle of about 30 boric acid suppositories or capsules, it's about $30, so much cheaper. Or folks can make it themselves, which is just a size 0 gelatin capsule, and it's 600 milligrams, but you fill it up with boric acid, and that is enough. And which species of yeast display budding on wet prep? Any of them can, but Candida glabrata is the most common one to be seen as just budding, but you can see budding even with albicans or any of the others. But glabrata is the classic butter, and albicans is the classic pseudohyphae. So if an uncircumcised male has fungal balanitis, what's the risk of his female partner getting a yeast infection? Excellent question. For men who are symptomatic, I think treatment is very reasonable. I can't quantify a risk of infection. And the other thing to remember is that a good 20% of us have yeast. We're colonized, but we don't respond. So having vulvovaginal candidiasis is both being colonized and responding to have symptoms. So let's see, this next one is for resistant candida, do I use boric acid plus something like ketoconazole and itraconazole? So I tend to start with just boric acid because things like ketoconazole, I'm a little more cautious with things. But honestly, for resistant candida, I think a multi-pronged approach is probably a good idea. And so, yeah, I think combining boric acid with something else is a great idea. Is it possible to see trich in older people? Yes, trich is one of the few STIs where the prevalence is in fact higher in older women, in those sort of 40 and up age group. I believe trich is actually more prevalent than in teenagers. So yes, you can see trich anytime. And I think Devika had asked if trich is dead or on a pap smear, do you still need to treat it? It is a fraught question. Trich causes cervicitis sometimes, and it's possible that it's just a sign of having active trich somewhere that you could transmit to a partner. But I don't have I'm a treater, so I would treat it, but I don't really have a data-based answer for that question about what, do you need to treat all trich or not? Can trich lead to PID? I don't think there's a really strong association between trich with PID. There is association with cervicitis. I don't think it's as strong an association with PID. It seems plausible, but I just don't think the data are there. Info on male to female or female to male transgender people, or recommend training. So certainly, it is not a population I have a ton of experience with. My friends who do have experience in that population do talk about, especially transgender men who are on testosterone, often get sort of a wacky vaginitis. And then a neovagina for a transgender woman also presents some very unique challenges. I think those data are emerging. One of the people who thinks about this a ton, at least from a surgical standpoint, is a woman named Cecile Unger. I think she's at Cleveland Clinic. The Mass General has just started a transgender health program, so I assume we'll have more trainings to come, but other folks on the chat might know more about resources for these populations. Contraindications for boric acid, and are there side effects or risks to using boric acid? So boric acid is a poison, should not be taken orally. If people have children in the home, definitely emphasize it needs to be kept safely. But really the side effect for participants or for patients is irritation in some people, but not most. Most people tolerate it pretty well. Many people ask about sex after boric acid and oral sex after boric acid. Penile vaginal sex is probably okay, although it might irritate the penis a little. So I tell people better to do it after sex than before. And oral sex, because it's a poison, I've said in the past 24 hours, but I really don't have I don't know. So 24 hours is what I've said. Is trichomoniasis ever not sexually transmitted? Not that I'm aware of. I'm gonna be, someone's gonna find a case report, but not to my knowledge. It's a sexually transmitted infection to the best of my knowledge. And have we seen any enhanced risk of genital HSV recurrent on patients on prolonged boric acid? I have not personally, and I've had several people, but that is totally anecdotal. And there are not really any, other than Jack's case series of his 51 people with boric acid, there are not really any published reports, although plenty of people use boric acid all the time. So I'm not aware of any HSV recurrence, but no one has looked to the best of my knowledge. Most of the time we see partners, but not patient, but not partners. And do I recommend partner therapy? So for yeast, I don't recommend partner therapy unless the partner is symptomatic, and then I tell them to see their own physician. For BV, I don't recommend male partner treatment. For a female partner, I would probably err on the side of asking the female partner to come in, but I think it would not be unreasonable to prescribe Metrogel for a female partner. I probably wouldn't do oral metronidazole, sight unseen, but Metrogel I feel pretty comfortable with.
This is Ina. We have a couple more questions coming in, and of course I could ask you 10 questions right now, but I'm not going to. But at any rate, we're going to collect the rest of the questions. There's just a few that are unanswered. We'll pass them along to you. I just want to take this opportunity to thank you so much for being on this call. Your vaginal knowledge is so deep, and it just makes me realize we have a lot more work to do, and so you have a long career ahead of you. But I also want to thank everyone that logged on to this webinar. I just want to mention that you will be getting a link to the recording of this session. A couple of people had their audio skip during the presentation. We did record it here. We will post that. We will also post a link to the slides. And just to let everybody know who's still on the call, because we still have quite a few of you, is that in September or October is going to be our next Expert Hour webinar. It's going to be on alternative dosing for HIV pre-exposure prophylaxis, the 211 protocol, which is on-demand PrEP dosing, like sort of a morning before and after pill, so to speak. Oliver Bacon from the San Francisco Department of Public Health is going to be with us to discuss, and then we're hoping to have a general dermatology webinar as well after that. But please join us in the fall for the PrEP 211 webinar, and thanks again to Caroline Mitchell, and thanks again to all of you. Have a good day.
Thanks, everybody.